Hello everyone. I am here today to talk about comparison of 35 sessions of EECP therapy with 50 sessions of EECP therapy in patients with low ejection fraction. Heart failure is the leading cause of morbidity and mortality all around the world, which accounts for around 8% of cardiovascular deaths irrespective of cause. In spite of being on optimum medical management, there is still subset of patients whom the symptoms are not controlled. Uh, In 1953, Kantrowitz demonstrated that coronary blood flow can be increased 20 to 40% by increasing diastolic blood pressure. Intra-aortic balloon pump counterpulsation is an invasive method for the same, and external enhanced external counterpulsation, that is ECP, which is non-invasive method for increasing coronary blood flow, which has been approved by US FDA as class 2B recommendation for management of refractory angina and heart failure. ECP consists of three cuffs, set of pair of three cuffs, which is tied around patient's lower limbs, which sequentially inflates and deflates, inflates during diastole, which increases the aortic diastolic pressure and increases the venous return, which in turn improves the coronary perfusion during diastole. The possible mechanism through which the effects are mediated is vascular endothelial growth factor, nitric oxide mediated vasodilatation, and angiogenesis. The classical duration of ECP therapy is 35 sessions. For patients with comorbidities or physical limiting factors, the therapy the therapy may be if less effective and additional hours of treatment may be warranted. ECP therapy may be required in about 20% of patients. There is no data comparing ECP therapy when given for longer duration as compared to conventional 35 sessions of therapy. So we aim to study the effect of ECP therapy given for longer duration, that is 50 sessions, and compare its effect with conventional 35 sessions therapy in patients with low ejection fraction. This was a single center prospective study of 22 patients with low ejection fraction, that is EF less than 35%. We included patients who were younger than 18 years with low ejection fraction, that is EF less than 35%, with or without NYHA class 2 or 3 breathlessness, who are not candidates for revascularization with ischemic heart disease, ischemic cardiomyopathy, and non-ischemic cardiomyopathy patients. We excluded patients who were younger than 18 years and who, in patients in whom ECP was contraindicated, that is, patients having controlled or uncontrolled arrhythmias, intracardiac devices such as pacemaker, ICDs, aortic insufficiency, severe pulmonary diseases, deep venous thrombosis, pulmonary arterial diseases, severe hypertension, bleeding disorders, abdominal aortic aneurysms, local infections. We compared different functional and echocardiographic parameters such as angina, NYHA class, mitral regurgitation, tricuspid regurgitation, ejection fraction, diastolic dysfunction, pulmonary arterial pressures, and also physical parameters such as SF36 score, quality of life score, and 6 minutes walk test. We compared these parameters at different timelines, that is at baseline, 6 weeks and 8 weeks. The first graph shows the improvement in angina at 6 weeks and 8 weeks compared to baseline, which was significant, found to be significant. Also, reduction, the improvement at 8 weeks compared to 6 weeks was found to be statistically significant. The next table shows NYHA class, comparison of NYHA class at different timelines, which shows there was significant improvement in NYHA class at 6 weeks and 8 weeks compared to baseline, and also the improvement at 8 weeks compared to 6 weeks was found to be significant. Next table shows the 6 minutes walk test, improvement in 6-minute walk test at 6 weeks and 8 weeks, which was found to be statistically significant at compared to baseline. And also at 8 weeks compared to 6 weeks, the improvement was statistically significant. Similarly, for SF36 quality of life score, which gradually improved uh, at 6 weeks and 8 weeks compared to baseline, was found to be significant. And also at 8 weeks compared to 6 weeks, the difference, the improvement was found to be significant. Then comes mitral regurgitation and tricuspid regurgitation, which showed improvement at 8 weeks, significant improvement at 8 weeks compared to baseline. But the improvement at 8 weeks compared to 6 weeks was not found to be statistically significant in both these parameters. In terms of ejection fraction, there was gradual improvement in ejection fraction at 6 weeks and 8 weeks compared to baseline, which was found to be statistically significant. But improvement at 8 weeks compared to 6 weeks was not significant. Then mean pulmonary arterial pressures were highest at the baseline, which gradually improved at 6 weeks and 8 weeks, which was statistically significant. But again, at 8 weeks compared to 6 weeks, the difference was not statistically significant. Diastolic dysfunction also showed significant improvement at different timelines, and at 8 weeks compared to 6 weeks, it was significant. Other parameters such as LV end diastolic diameter and end systolic diameter, though it showed decreasing trend in the diameters, LV diameters, that difference was not found to be statistically significant. Hence, we observed that there is improvement in functional capacity suggested by SF36 score, 6 minutes walk test, reduced anginal episodes, NYHA class, breathlessness, then improved diastolic dysfunction after 50 sessions, that is 8 weeks of therapy, compared to 35 sessions, that is 6 weeks of therapy. Though there has not been significant improvement observed in terms of ejection fraction, pulmonary arterial pressures, grades of MR and TR at 50 sessions, that is 8 weeks compared to 6 weeks, that is 35 sessions. This study shows the favorable outcomes in terms of various clinical, functional, and echocardiographic parameters on extension of standard 35 sessions of ECP therapy to 50 sessions of ECP therapy. Hence, the standard therapy of ECP can be extended to 50 sessions in mentioned subgroup of patients. Thank you.